why you may evaluate a rehabilitation program, I think it's important to think of which questions you're answering program. So there will be a short practical demonstration, so I will need a volunteer. We'll get to that in a minute. So with regards to why you may evaluate a rehabilitation program, I think it's important to think of which questions you're answering so you can select the most appropriate variables, because there are so many measures that you can do when you want to evaluate a pulmonary rehab program, and I think a lot of programs can get bogged down on collecting a lot of information where you don't necessarily need too much to evaluate the change. So I think these are the questions that you may consider asking. You may ask, who's attending your program? Is the program conferring changes for the participants? So this is about the effectiveness of the program. How does your program compare with others, both in the literature, but also within your country or within your region? Is the program cost effective? Do your patients enjoy it? And what are the opportunities for improvement? So I'm going to talk through each of these for the next 30 minutes, but I'll focus on this one here because I think this is the most important to demonstrate that our programs are effective. So who is attending the program? And these are just basic descriptive variables. I won't spend long on them, but these are basically outcomes or variables that you don't necessarily expect to change as a result of coming to your program. So we record patients' age, gender, height, weight, marital status, and we also look at where they live, their region, for postcode, or you may call it zip code, I'm not sure. We also document their diagnosis and comorbid or multiple comorbid conditions. And I think this is important because it tells us whether we may need to modify our exercise training program or some additional safety considerations. We also take measures of, or document measures of lung function, often just spirometry, to get an idea about the range of disease severities who are attending our program.
So you do it within the rehabilitation program?
Sorry, we do it within the rehabilitation. Often that we ask the referring physician to have done spirometry and write the results down for us. But the measures of lung function don't tell you, as you know, about how the patient's performing during day-to-day life. So for that, we also measure, or we ask the patients to grade themselves on the Medical Research Council scale. Is everyone familiar with that scale? So it's 5 statements, and the patient chooses which statement best reflects how limited they are during day-to-day life because of their dyspnea. So at the top, it's I only get breathless with walking upstairs or hills or when I rush. So they've got very mild limitation. And at the end of the scale, it's I'm too breathless to leave the house or I'm breathless with showering and dressing. So it's a range in between. And we also take some information about who's referred the patient, because I think it tells you who are the respiratory physicians that are endorsing the program. There's also an opportunity there. If you know there are physicians that are not referring and you feel they should, then there are perhaps people that you can raise the awareness of the program with to facilitate referrals. I changed the order of the slides a little, so I apologise. I think this is the only one that's out of place. I think the other thing that we're increasingly recognising is the importance of anxiety and depression in these patients. And there are a range of questionnaires that you may choose to go through to look at to see whether patients have anxiety and depression. We don't specifically go through the questionnaires, and I think one of the things you do need to think about is overlap. So what I mean by that is a lot of the questionnaires will use breathlessness as the symptom for anxiety, but we know that patients with COPD are breathless. So it'll overrate how much anxiety they have. And likewise, a lot of the questionnaires will use fatigue as their symptom of depression. But we know our patients with COPD have fatigue. So if you are going to do a questionnaire for anxiety and depression, I would look at the questions and try and make sure that the anxiety questions are not all about breathlessness and the depression questions are not all about fatigue, because you'll get so many false positives. This is some questions, the simple screening questions that have been validated in the literature in a primary healthcare setting to try and pick up patients that may have clinically important anxiety and depression. So in the past month, have you been bothered a lot by little pleasure or interest in doing things, feeling down, depressed or hopeless? So that's clearly a screening question for depression. In the past month, have you been bothered a lot by nerves or feeling anxious or on the edge, worrying about a lot of different things? That's your question for anxiety. And the last one, during the last month, have you had an anxiety attack? Which is a question for panic disorder. And I think that these are very useful because they will tell you about barriers to attending or completing a pulmonary rehab program, but also they're a red flag that perhaps this patient needs medical management for a clinically important anxiety or depression problem or referral to a mental health care professional. So I want to focus really on this, is what outcome measures may you choose when you're looking to see whether a program confers changes. And from those of you who I've spoken to during the breaks, I think that you probably know all of this, so we'll just see how we go. I think when you want to see what outcomes you're going to select, you should pick the ones that are most likely to change. So we know that pulmonary rehabilitation has achieved the strongest level of evidence for changing exercise capacity, so we need an outcome measure around that. For changing symptoms of dyspnea and fatigue, so we need an outcome measure around that. And health-related quality of life. So I think you can get away with 3 outcomes which are likely to show benefit. So let's talk through each of those. With regards to the assessment of exercise capacity, we've already had quite a lot of discussion during this meeting about the 2 different types of tests. So either laboratory-based tests of exercise capacity, which are either done on electronically braked bike or a treadmill, and they usually involve the patients coming in and doing an incremental protocol. These are not within the scope of all clinical services, so they're expensive, they're difficult to do, they're resource intensive, you often need a physician in the room. And if you run a program that's away from a major teaching hospital, like we do in Australia, some of our programs, this just isn't feasible. They don't have access to electronically braked bikes to do these type tests. So for the sake of, I'm not suggesting they're not valuable, they are, it's just that they're not realistic for all programs. So what I want to focus on today is field-based assessments, and I think the 3 that are most commonly used in clinical practice are the 6-minute walk test, the incremental shuttle walk test, and the endurance shuttle walk test. So I think, who here uses a 6-minute walk test? So most people. Incremental? You use one of those. And an endurance? Have you used an endurance shuttle walk? Both, okay. So we'll talk through each of them, but the 6-minute walk test is usually still the most popular. I've just put up here to remind myself, although these field-based assessments, we advertise them as simple, quick, easy, inexpensive, all those wonderful things, in order to do them properly, in order to get good results, you really need to do 2 tests at baseline, because the patients do have a significant learning effect of up to around about 10%. And if you haven't accounted for that improvement just for them getting used to doing the test, then you'll overinflate the effectiveness of your program. Because if you just do the test twice, they'll get better by 10%. So it's important to at least do 1 practice walk. So let's talk about the 6-minute walk test. The 6-minute walk test is still, I think, the test of choice. It's very, very popular in Australia. It's popular in Canada. It's popular here.
In England.
And sorry?
In England, it's very popular there.
Yeah, the shuttle test is the one that's used most commonly in the UK, though. So the 6-minute walk test is popular, and it's become more popular thanks to the American Thoracic Society publishing guidelines telling us all how we should do it. And I think I've included a copy, or Amnon's been kind enough to include a copy of that statement in your handouts.
Yes.
So there's information there about test instructions and standardisation. It's claimed to be a test that's self-paced, in that the patients are allowed to walk at whatever pace they choose. But just keep in mind, this is supposed to be a maximal effort test for these patients. So although they're allowed to choose their pace, we do ask them to cover as much ground as they can in 6 minutes. So they should be walking at the fastest pace they think is going to be sustainable for 6 minutes. It's not a stroll. You know, it's self-paced, but they should be walking at the fastest pace they think they can manage. One of the lovely things about the 6-minute walk test is the patient's allowed to stop and rest. So if they experience intolerable symptoms, they're allowed to stop and rest, and then they could just get up and continue when they feel they can. And that's a nice thing about the test, I think. But because it's self-paced and because there's a few variables, it's very important to optimise the reproducibility. So to try and make sure you've got a stable baseline, because if you've got a stable baseline and then you see change, you can be more confident that change is real, as opposed to having a very variable baseline. And ways to optimise the reproducibility are with practice walks. And we do at least 1 practice walk for each of our patients. And as I said, we see on average a 10% improvement. Standardising the encouragement, standardising the instructions, and the ATS are pretty strict about how you should do that. Standardising the track on which they do the test. So what I mean by that is it going to be an out and back track, like a straight track, or one that's around the ward, like a circular track. And it doesn't really matter which one you go with, providing it's the same every time. And we also standardise bronchodilator use. So if patients want to use a bronchodilator before their first test, that's fine. We just ask they would do the same thing before their post-rehab assessment. The incremental shuttle walk test. How many here haven't seen this, haven't heard of this test? Is there anyone here that hasn't heard of this at all? Okay. So the incremental shuttle walk test was developed by Sally Singh in Leicester in the UK in 1992. And it's the test that's used predominantly in the UK. And it's also the test that's used predominantly in New Zealand. And it's used in a couple of other centres throughout the world. So it is quite popular. The incremental shuttle walk test is externally paced. So in other words, we dictate how fast the patient's got to walk, and I'll speak about that in a second. And it's analogous to an incremental cycloergometry test. So like when they come into the lab and we get them to cycle harder and harder each minute, for the incremental shuttle walk test, we get them to walk faster and faster each minute. So it's coined as a test that's maximal and progressive, and the test ends when the patient's too breathless or they can no longer keep up with the set pace. And I'll talk about that in the next slide. One of the major differences between this test and the 6-minute is they're not allowed to rest. So if midway through the test they start feeling intolerable symptoms and they want to rest, that's the end of the test. They're not allowed to rest and continue. So for those of you who have done this test, you'll know this. This is the course. So it's set up with 2 cones or witches' hats, 9 metres apart, and that allows for a 10-metre track because around the edges here they walk a little bit further to walk around the cone. So it's a 10-metre course, but the cones are 9 metres apart. And there's a CD player usually in the corner. And the CD includes the standardised instructions. The lady comes on and speaks to you in a lovely British accent and tells the patient what's going on. Then the patient gets up and starts here. And for the first minute, they've got 20 seconds to complete each shuttle. So for the first minute, this person will get 20 seconds to walk down here. And then they should be aiming to turn this cone when they hear the next beep, which is 20 seconds away. And they come down here, they've got another 20 seconds to get down here, another 20 seconds to get down here. 20 seconds is a long, long time to cover 10 metres. I've never had a patient that can't do it. I've got patients that can only do that, but they can almost all manage at least the first level. And then they'll hear a triple bleep, which signifies that it's going to get faster, and then they've got less time to basically cover this. And they continue until they can't get within half a metre of the cone, and that signifies the end of the test. So when they start missing the beeps, when they don't get there in time, that's the end. The endurance shuttle walk test is a kind of a modified version of the incremental shuttle walk test. It's also externally paced, so again we tell the patients how fast they've got to walk, and it's analogous to a constant load test on a bike. So in other words, they've done an incremental test, we know where maximum is, and we set a percentage at a high percentage of their maximum, about 85%, and that's the workload for the whole test. They do a 90-second warm-up just to get familiar with the course and familiar with the CD, and then they're off at a constant submaximal pace. That's about 85% of their maximum. And like the incremental, the test ends when the patients are too breathless or can no longer keep up with the set pace. If they do a submaximal performance during their incremental, or just because patients vary on days to day, you can sometimes get the pace wrong. And the patient can just be cruising along at 17, 18 minutes and they don't look like they're getting any worse. So they also have built in here, thank you, they've also built in here that you stop after 20 minutes and pick a higher pace. So if in the first test they're getting to 20 minutes, you should be stopping and picking another test. Thank you. And like the incremental, they're not allowed to rest. I think when you're choosing, so you've got a choice here. You've got 6-minute incremental endurance. And there's a couple of things to think about which one you would pick. With regards to which one you would pick, one thing to think about is how you will interpret the changes. And something that's become very popular recently is this concept of the minimal clinically important difference. Have you all heard of this, the MCID? Yeah. So the minimal clinically important difference is the amount that an average patient needs to change in order to say they've detected that change. So it's the amount that a patient will notice. Okay. So for a 6-minute walk test, we originally thought it was around about 54 metres, and that was actually a study that Roger Goldstein did.
The minimally important?
Well, it's not necessarily about, you're right, how have they validated? They haven't validated it, but they have identified it in a couple of different ways. There's two methodologies that you can use to develop a minimal clinically important difference. One is anchoring it. So you ask the patient at the end of a pulmonary rehab program to rate their change from I've improved lots to I've gone backwards lots. And in the middle would be no change. And then they basically group the patients according and look at the difference between those, and they can get an idea about what the average patient has said they've needed to change by in order to say they've noticed a difference. There's another way, but it's a statistical way.
We believe that for patients and for healthy individuals,
Very different. Very different. And I think it differs between interventions. I think for pulmonary rehabilitation, your MCIDs will be bigger because it's about what the patient notices, but also about what the patient perceives to be important. And important will be about how much effort they've needed to put in to get that change. So for a bronchodilator, no effort, squirt and off they go. If they improve 5 metres, they may think that's worth the effort and that's important. But for pulmonary rehabilitation, they're coming in twice a week for 8 weeks, a lot of effort. You're going to want to see something that's reasonable for them to say that's important, it's been worth the effort. It was originally 54 metres. We probably believe it's now closer to 25 metres. The endurance shuttle walk's been established at about 48, and the incremental, and the endurance shuttle walk, we're not quite sure, but we think it's around about 186 seconds, or around about 3 minutes. The big mistake with these that people make is they use them to look at changes in an individual patient. So when it used to be 54 metres, for example, when I first started pulmonary rehab, we'd have a patient come through and they'd do a 6-minute walk test before, they'd do a 6-minute walk test after, and they'd improved by 50 metres. And we'd be going, oh my goodness, that's awful, it's below the 54 metres. And yet if someone gets 55 metres, it's bottles of champagne and we're all happy thinking the patient's improved. Minimal clinically important differences were established in groups of patients. It's about a group response. So it's how you evaluate your program, not how you evaluate your patient. So it's whether your program, on average, confers an improvement for all of your patients that's at least 25 metres, not about an individual. And the other thing I think that's useful when you're going to interpret data or help patients to interpret data are normative values. And we've spoken a bit about this morning already, is that when I do a 6-minute walk test with a patient and they may achieve 330 metres, and so they finish the test, they say, Kylie, how'd I go? 330 metres. Is that good? And they're used to saying things to me, but my lungs are 40%. And of course, they're talking about their FEV1 percent predicted. And patients are used to hearing numbers expressed as a percent predicted. 330 means nothing, but 76% of normal means they've lost that as a result of their lung function. They understand that. So there's been a real interest just in the last decade about establishing normal 6-minute walk test values. And there is a range of countries here, and if you go in and Google, they're quite easy to find. But you can estimate a normal 6-minute walk test using height and weight, and then you can express it as a percentage of the predicted and say to your patients, well, you've lost 40% of what's normal walking capacity, which is a useful message for them. And this has also been done for the incremental shuttle walk test, just recently, in fact. So that's how you may interpret it. And then really the question when you're going to choose is about responsiveness. So where are you going to see the biggest change? Without any doubt, the endurance shuttle walk test of the 3 tests is the single most responsive test. Without any doubt, it's the most responsive. The problem is that in clinical practice, it takes several tests to set up to get right, because you've got to do 2 incrementals, one at the beginning, another, because they'll get better, to account for learning, effect and practice. So you've done 2 incrementals. These tests may have gone on for 10 minutes. Patients need to rest in between them. You then bring them in, probably on a different day now, and do an endurance shuttle walk test. You may pick the speed that's slightly wrong. They go out to 20 minutes. You've got to pick another test. So far, we've done 4 hours of assessment, and we still don't have a number on these patients. So the endurance shuttle walk test is extremely responsive, and it's been used a lot in the literature, in the research, because you get big changes. But in clinical practice, we're not quite there yet, because it's cumbersome on the clinicians to do. So that really leaves us with the incremental and the 6-minute. Which one to pick? Well, it's not an easy question to answer. I think for high-level patients, if you're seeing patients come through that are quite high level, so have quite modest disability, I would advocate using the incremental. The reason being is that if someone gets a 6-minute walk distance of around about 550 at baseline, their ability to walk faster at post-rehab is limited by stride length. And you're not going to grow any taller during your rehab program. So if you're getting baselines of about 500 or 550, you've got a ceiling effect on your 6-minute walk test, and you're not going to necessarily see as big a change as you could. The incremental shuttle walk test, the modified version, which has 15 levels, will actually allow your patients to run. I've had 2 patients try, wish they didn't. So you can run it, because it was developed, in fact, for kids with CF who want to run during this test. So if you've got basically high-level patients, I would advocate the incremental. If you've got low-level patients, I think the 6-minute is better, because for patients who are very low level, they can increase their 6-minute walk distance in 2 ways. They can either walk a bit faster during the test, or they can rest less. So they've got 2 opportunities to increase their distance. The other things to consider are other aspects about the patient. Are they using ambulatory oxygen? Are they using a rollator? Do they have musculoskeletal problems, so knee problems, hip problems, back problems? And if they have any of those, the incremental is quite tough, because they're turning every 10 metres. And it's difficult to haul your oxygen around those cones every 10 metres, or walk with a rollator without knocking them every 10 metres. Sorry?
Even without it.
That's right.
The circus
It's tight.
very difficult.
So some people get around it by putting tape down on the ground, so they're not actually knocking the cones if you really want to use them. But if patients have got knee pain, you're going to stir it up, getting them to do hairpin turns every 10 metres, I think. So that really leads you to think maybe the 6-minute walk test is the way to go. The 6-minute walk test is badged or coined or labelled in the literature as a test of submaximal exercise capacity. Everyone thinks it's submaximal, and I'm here to dispel that myth. I don't think it is submaximal. I think it's very near maximal. And this is data that I collected with Roger Goldstein when I was doing my postdoc there. This is rate of oxygen uptake, so a gold standard measure of aerobic capacity, and time here on the x-axis. And we did 4 tests in random order, same group of patients. This is the bike test, so the kind of the classic laboratory-based test of maximum exercise capacity. This is an incremental shuttle walk test. Same patients. This is the 6-minute walk test, and this is the endurance shuttle walk test. These patients have an FEV1 of 51% predicted. They all end up in the same spot. They're ventilatory limited. They're ventilatory limited. So if you...
How was the VO2 measured?
With a portable gas analysis system, COSMED, yep. So if you look at this, if you actually talk about VO2 being a test of exercise capacity or peak exercise capacity, it's very difficult to look at these data here and say that the 6-minute walk test isn't a maximal test of exercise capacity. They're getting the same VO2. They get the same heart rate, by the way. And the other thing that's alarming is that they actually get more maximal responses in some of the outcomes. So in terms of desaturation, this is what happened on the bike. They don't desaturate much. And look with the walking. They all nosedive down to here. And this is probably actually an underestimate, because if they desaturated too much, we excluded them or stopped them. So you actually get a more maximal desaturation response with the 6-minute walk test than you will in the lab.
Well,
so if they don't...
use much more bunch of muscles.
That's
more, of course.
the actual... That's part the reason. The other reason they think is because you get more... With biking, you get more specific load on the quadriceps, so you ventilate more. You ventilate more when you, and that's been demonstrated in the literature, you demonstrate more on the bike. You ventilate more on the bike. And because you ventilate more, you desaturate less. Richard Casaburi's work is the one to look at for that. So I'm just saying, 6-minute walk test, I don't think is a submaximal test. You're getting the same VO2, the same heart rate, and you're getting greater desaturation than what you're getting in the lab.
You have just the idea that it's about 15% different between maximal VO2 in a bike compared to treadmill.
In healthies. In healthies, because there's more exercising muscle mass. In COPD, they're ventilatory limited. It's not about muscle mass, it's about ventilation. That's my experience.
You're right.
So the safety considerations. So if we're thinking now the 6-minute walk test is eliciting maximal and near maximum responses, we need to be careful. So our safety consideration, we've adopted the ACCP recommendations for contraindications to exercise testing and criteria for termination. You can find those easily if you Google them. And they're easy to look at. We monitor heart rate, and I'll show you that in a second, and we use a polar heart rate monitor when we do all of our 6-minute walk tests. I don't believe heart rate's off oximeters because of motion artifact. So when I'm doing a 6-minute walk test and the patients are swinging their arms, I don't believe anything I get from a heart rate reading on that. I also monitor the patients very closely for symptoms of myocardial ischemia, and I add extra warnings in over and on top of what the ATS recommends. Regardless of what the ATS says, I also monitor arterial oxygen saturation, because you're going to see a bigger drop when they walk than when they bike. So even if they've had a stress test in the lab or a cardiopulmonary exercise test in the lab on the bike, and the report comes back that there was minimal desaturation, they're very likely to still desaturate when they walk. What happens on the bike and what happens when they walk, very different. And you may consider doing a screening test for high-risk patients. Having said that, I think I said earlier today, we've done, in the paper we just published about 2 years ago, we've done 741 6-minute walk tests in patients that have been referred to pulmonary rehab with moderate to severe disease that have never done a screening test prior. And we've had 2 adverse events. One was chest pain that resolved, and the other, they had an arrhythmia, which also resolved, neither of which were life-threatening. It's a safe test to do in the hands of an experienced operator, if you know what you're doing.
Really desaturated.
Yes, we have a threshold. We stop them when they get to 80%.
How do you measure the saturation while they're walking? Or?
Yeah, we measure it while they're walking. We measure it with an oximeter with them, and we put them on a long leash. I'll show you in a second.
Okay, yeah.
A long leash.
Yeah, long leash.
Yeah.
But at what time do you stop them? At what saturation you stop?
80 and falling. 80 and falling, which is what the ACCP guidelines state.
18 falling?
80, 80, and falling.
Okay.
Down, below 80.
80 and falling. So if they're 80 and stable, I would leave them, but they don't tend to be stable. And the point is at 80, who knows what the saturations are? The oximeters aren't real at that point.
Usually you said like 88, 87 is the...
If I stop my patients at 87, I would stop all my patients. And the ACCP guidelines recommend 80.
You said only 2 cases where...
That's right.
Yes.
And we stop them at 80. That's when we stop them at 80.
But you test them always without the oxygen support?
Unless they come with oxygen. If they've been prescribed oxygen, I put them on oxygen. They use their own. Yeah, they use their own. I just want to talk quickly about a couple of the others. Dyspnea and fatigue. So dyspnea and fatigue are embedded within your quality of life questionnaires. So I'm going to talk about that in the next slide. Dyspnea and fatigue during daily life. I just want to talk here about dyspnea and fatigue during exercise testing. So I think most of you know about the Borg. Everyone's used the Borg scale, yeah? So rates from 0 to 10 is useful. And we actually don't know really what the minimal clinically important difference is, but we believe it to be 1 point. Experts think it's 1 point. I think it's very useful to get dyspnea scores on your patients before and after the 6-minute walk test because it helps you to interpret results. So for example, if a patient comes to me and I do a 6-minute walk test prior to training and they're 450, and then they do their rehab program, they do another test with me afterwards and they're 450, you would think, oh my goodness, nothing's changed. But if the 450 they managed before rehab, they managed to do that with a dyspnea of 7, and now after rehab they're doing 450 with a dyspnea of 2, that's a huge improvement. They're just experiencing less symptom. And the other reason that it's useful, you've no doubt read in the literature, they use it a lot to look at ISO time or ISO work rate. So what I mean by that is at the same level during tests. So usually done in the lab, but if you've done a constant power test and you go 5 minutes in your first test and you go 10 minutes in your second test, they look at dyspnea scores at 5 minutes in both tests and they're very, very responsive.
So do you do ISO time?
With a 6-minute?
Yeah,
you can't because it's not ISO. Yeah, that's right. You could with the incremental,
only
but
the bike.
or incremental. Yeah. The other outcomes are health-related quality of life, and as you all know, this is someone's perception and reaction to their health status. I think you can broadly classify health-related quality of life in 2 ways. Either as a generic, which is the SF36, I think is the most common one, so the short form 36. The SF36 is very, very useful if you want to compare quality of life, usually in research settings, in your patients with other diseases. So heart failure, HIV, cancer, whatever. So you can use it across a range of different diseases and compare health-related quality of life. But it's not very responsive. It doesn't change much with pulmonary rehab. So the 2 disease-specific questionnaires are the Chronic Respiratory Disease Questionnaire and the St George. And I get the impression that people here are using the St George.
Yes.
Is that right?
Yes.
I've put this up just for the sake of completeness because I know you've got your slides there, but I think when you're administering a questionnaire, it's worthwhile just thinking about how you're going to do it, interview, telephone or self, and I've just listed a few of the strengths and weaknesses, which I won't run through in the view of time. So the Chronic Respiratory Disease Questionnaire, who has seen this one? If you're not using it, has everyone seen this one? No? So it comprises 4 domains. Dyspnea, so this is the dyspnea question, an example of a dyspnea question. I would now like you to describe how much shortness of breath you've experienced during the last 2 weeks while doing the 5 most important activities you've selected. That's an example of a dyspnea question. This is fatigue, obviously. This is emotional function. So in general, I would like you to describe how much time during the last 2 weeks you felt frustrated or impatient. And remember, we've talked a bit today about mastery or coping or confidence with your disease, and this is a mastery question. So in the last 2 weeks, how much time did you feel very confident and sure that you could deal with your disease? So that's the 4 domains, and when you sum them together, that's overall health-related quality of life. I'm sorry about how this projects, but I know you've got it in your books, and you guys know this questionnaire anyway. So this is an example of a St George, and as you know, there are 4 subdomains. There's symptoms, and this is an example of symptoms where they talk about phlegm, sputum, same thing, cough, wheeze, breathlessness. And then the other 2 subdomains are activity and impact. And when you sum them all together, it's health-related quality of life. So I'm going to throw a cat amongst the pigeons and say that at home, we actually use the CIDQ, not the St George. And I don't think it matters. Both are valid and reliable. So if you're going to choose one over the other, I don't think you can say that one's a better instrument than the other because that's not true. They're both the same, really. I think both are interpretable. We know what the minimal clinically important difference is for both. For the CIDQ, it's about 0.5 points per item, or 10 for the total score, and the St George is 4 points. So if your program, on average, confers a change in the St George of 4 points, the average patient will notice that. The average patient will say they've improved. We use the CRDQ for 3 reasons. One, the time frame over which the questions are asked I think are better. You ask the time for them to reflect on what's happened over the last 2 weeks, not over these days, whatever these days means. And in fact, some of the older versions of the St George asked over the last year. I can't remember what I did last week, never mind last year. So I don't know that last year's a great way to go with these patients. But this is over 2 weeks, so they've got a definite period of time in mind. The CRDQ is easier to score. It's just maths, you add it up. Whereas the St George involves some elaborate weighting system, which can be quite difficult if you don't have the program for it. But the main reason we use it is because it can assist with exercise prescription. So for the individualised dyspnea domain of the CRDQ, you ask the patients to nominate the 5 activities that they do frequently and that are important to them during day-to-day life that are limited by dyspnea. And based on that, we can tailor our exercise training program. If my patients report all 5 activities, upper limb exercise, they'll be doing a lot of upper limb exercise in my program. So I can help tailor the program based on what activities are important to them, because I've asked about it. Has everyone heard of the BODE? No? So if you read the literature in this area, multidimensional indices are becoming very, very in vogue. And Roger alluded to this during his presentation. And this is one example where you basically score points for each of these domains and you add them together into a composite score. So the BODE, which is BODE, gives you points for body mass index. So if you're skinny, you score worse. Airflow obstruction, if you've got poor lung function, you score worse. Dyspnea, if you've got more dyspnea, you score worse. And exercise capacity, obviously, if you've got less 6-minute walk distance, you score worse. And the scores range from 0 to 10, with 10 being bad. More advanced disease. And the good thing about BODE is that it combines both the pulmonary, because it's got this, but also the systemic components, so exercise capacity and a reduction in muscle mass. And because of that, when you score this and get a score for this, this is one of, if not the, single strongest predictor of survival. Much better than FEV1, because it actually accounts for some of these systemic manifestations. And so people in pulmonary rehab programs are collecting BODE because they believe if they can change BODE, they can change survival. It's not quite the same as doing a cause and effect study, but it's along the same line. I've just put this up again for the sake of completeness. You know, there are literally hundreds of ways to assess patients, but I think we've talked about the big ones. So you could, if you wanted to, and these are usually within the realm of research, but you could look at arm function, you can look at muscle force, you can look at balance, physical activity, disease-specific knowledge. It goes on and on. Just briefly then, when you're choosing outcome measures, I think you need to choose those that are responsive and useful, but also it's very important to be strategic and keep in mind what other centres are using and what the literature is using, so you can compare with other studies. So I would advocate that you use a small number, don't go crazy with assessments, a small number of very standardised assessments and do them well. Do a small number of exercise assessments or a small number of assessments and do them very well. And pick outcomes that are common in the literature, like in the meta-analyses, so you can look and compare, but also in other programs here in Israel. So you can actually start comparing your outcomes against others. In our program, we use the 6-minute walk, the chronic respiratory disease questionnaire and dyspnea at the end of a 6-minute walk test. PORC score. This is kind of the you have to talk about it slide. So, you know, it's only a matter of time until people are going to ask you whether your program's saving them money. So we also collect this data, which is difficult to collect. It's very difficult to collect good healthcare utilisation data. Patients are poor historians. They don't remember. But we ask them about visits to family doctors, emergency rooms, admissions and lengths of stay. And we also ask them about severity of exacerbations and exacerbation frequency. Because I think within a comprehensive pulmonary rehab program that includes self-management, there's quite strong evidence that it will reduce the duration of exacerbations and also the severity of exacerbations. And one way of grading severity of exacerbations is about what medical management they required. So if they can be managed at home just with some increase in medication, that's a mild exacerbation. If they need to come see a doctor, that's moderate. And if they need to come to a hospital, that's severe. It's simple. I think if you're going to do a pulmonary rehab program, it's useful to think about asking the patients whether they've enjoyed the program. They're your biggest advocates. So we do questionnaires for everyone that attends over a 1-month period, so we're not overwhelmed with these data. Our questions focus on content, not on personalities or personnel. We ask them to write down their strengths and weaknesses, or what they perceive their strengths and weaknesses of the programs are. We encourage open-ended questions and areas for improvement, and we also guarantee that their responses will remain anonymous because I think you'll get an increased response rate and you'll get more honest answers. And finally, I think this is something that's very important, particularly for new programs that are starting up, is to get an idea about these outcomes. So uptake. So of those who are referred, how many come to at least one session? How many uptake the program? And if they don't, why not? Attendance. So if you're going to offer 16 sessions, so 2 a week for 6 weeks, how many people attend those 16 sessions? So what's attendance? So attrition of those who start the program, how many don't complete? So how many drop off and why? And then looking for barriers. Because I think this is how you can actually, if you've got data on this, it will help to make a stronger case to lobby. To say, you know, this many patients were referred, 20 didn't even attend, and the biggest issue is they need to pay for parking. So can we have some funding for that, or is there some way you might be able to sort that out? So we ask about these issues. I know we talked a little bit about smoking status this morning, and you know, smokers who attend pulmonary rehab will confer the same level of benefit. They will confer the same change, but they're less likely to complete. And they're less likely to complete for 2 reasons. One, they feel ostracised by their ex-smoking counterparts. And they also are more likely to have exacerbations. They get sicker because they're producing more mucus. So we allow smokers to come, but smokers drop out because they feel ostracised by their ex-smoking counterparts. So to summarise, I think when you're thinking about selecting assessments, you should consider the reasons. You should choose outcome measures that are common to programs in your area and have known measurement properties, and you should be familiar with how to interpret the changes. So I just wanted to do a really quick, and it's going to be really quick, example of how I set up a 6-minute walk test. Can I have a volunteer, and preferably a male, who can come sit here, and I promise I'll be very nice to you. Oh, thank you.
A nice volunteer.
Are you a nice volunteer? And if you guys turn to page 59 of your booklets, we're going to work through that together. Just take a seat in the chair, kind sir. This is my patient with COPD. You're looking very well today. Yes, that's right. So have you got the training booklet, I think, is on page 59, is that right, in your guide? So I'm in debt to my colleagues who put this together for me. So this isn't my development. This is the people who started the program at Charlie's, so the hospital I work in. So sorry. So I think this is a very useful, and this is a guide they've allowed me to share with you today. So I hope it's useful. So these are some of the basic information that they collect: their age. They get an idea about what the patient's heart rate maximum would be. They write down on this form, as well as on their initial assessment, any medications they're concerned about from a cardiovascular perspective. So paying particular attention to beta blockers, and they would also write down their blood pressure. And on the first day they come to do the assessment, they indicate who's doing the test. So whether it's SJ, who's one of the physios, or Nola Chechens, who's the other physio. They write down the date and whether or not the patient's taken bronchodilators. And then before doing the test, they would set the patient up. So I'm going to put just some equipment on, but I'm just going to show you roughly how it goes. We use a heart rate monitor, a polar heart rate monitor, to monitor heart rate. These are available in Australia for around about $100. So what's that, 400 shekels, I think? So I'm doing good at this. So they're expensive, but they're not prohibitively expensive. They're not outrageous.
You sound like a Jewish now, huh?
I know, I am. And on here, we use ultrasound gel to increase conductivity, and this sits just here. So it actually sits on the skin, but I'm not going to do this to this poor man. I'm just going to put this around here to show. Excuse me for a second. Can you just hold this for me out the front?
Yeah.
Thank you. I don't know how tight this is for you. It's going to be a bit snug, my friend.
Don't worry.
Oh, sugar. Thank you. There we are. And then, so we can monitor the heart rate during the test, we use the watch, it's a transmission device, and we actually pin this to the back of their shirt. And we pin it because we follow the patient from behind with the oximeter, so we're not pacing them. And also the watch from behind means they can't look at their heart rate. Patients very soon get fixated on numbers, and I don't want them thinking about the numbers, I want them to think about their symptoms. Excuse me, I'm going to try not to destroy your shirt while you're here at this conference. Okay, then before we get going, feeling okay?
Yeah, perfect. Yeah. Still sitting.
That's right, I know. You're supposed to be very breathless. So before we get going, I would read the standardised instructions. So we've developed a protocol that we would follow, and this is based on the American Thoracic Society recommendations. So I literally read the instructions to the patient every time before every test. So I'm sure it's been standardised. So I'm going to read them out loud now. You are now going to do a 6-minute walk test. The object of this test is to walk as far as possible in 6 minutes. You'll walk back and forth in this hallway. 6 minutes is a long time to walk, so you'll be exerting yourself. You will probably get out of breath or become exhausted. You are permitted to slow down, to stop, and to rest as necessary. You may lean against the wall whilst resting, but resume walking as soon as you are able. You should walk back and forth around these cones. I would have set cones up. And you should pivot briskly around the cones and continue back up the other way without hesitation. I'm now going to show you. So then you demonstrate. So I've normally got cones on the floor 30 metres apart, and you just demonstrate to the patient. I want them to turn and go straight back down. Please watch the way I turn without hesitation. Are you ready to do that?
Yes.
That's good. I am now going to write down the number of laps that you complete. I will mark a lap each time you pass a cone. Remember, the object of this test is to walk as far as possible in 6 minutes, but do not run or jog. And then I add the extra safety thing, and the ATS I don't think has in. Please do not talk during the test unless you have a problem or I ask you a question, but you must stop walking immediately and let me know if you experience any chest pain, chest tightness, dizziness or lightheadedness. I expect you to feel breathless. If you experience any other sensation, you must let me know about it immediately. So I give them standard instructions. I then teach them the Borg scale. There's instructions on the back, Borg scale on the front. This, my friend, is a scale for rating breathlessness. The number at the top represents no breathless. The number 10 represents the most severe or greatest breathlessness you've ever experienced. Please point to a number that represents your level of breathlessness at the moment. Okay. So he's picked 0. So he would get a baseline assessment here of 0. If you want to, you can take dizziness during the test, but you don't have to.
But you said that you had a long leash.
I do have a long leash, but I didn't bring it from Australia.
No, usually it's 30 meters.
30 metres.
Oh,
That's
okay,
right.
so
So I'm actually just going to put this on your left hand. Turn this on. And it's a good idea to wait for some good baseline readings. You're okay. I've done this before. So then when we've got some good baseline readings, I take the heart rate from back here. So his heart rate, well, I would have that turned on. I haven't actually got it working at the moment, but the heart rate would be here because it's not on his skin. So I would take the heart rate from here and write that down as his pre, and take the SpO2 from here and write that down. I would have set the track up, so I just get you to come over here for me, kind sir. Stand here. Are you ready to do this test?
I'm going over there.
You're going very slowly, trust me, to this door, and when we get there, I'll tell you how to turn. So very slowly for me, okay?
Okay.
All right, off you go, start. And when I get to the end here, sorry, keep going. When you get to the end, if you can turn in this direction for me, I guide the patient so I don't get too caught up. Round this way for me, sir. And back and forth we go for 6 whole minutes. Each minute here, I've got standardised encouragement that I read, and in this direction for me, sir. And each minute I will write down his heart rate, his SpO2, keep going for me, you're fine. So each minute I write down his heart rate, his SpO2, and give the encouragement each minute. And turn around for me once more. And at home, like I said, we've got a very long leash, so I don't feel like I'm pacing the patient. If he needs to stop and rest, you're feeling terribly breathless now, if you can just stop and rest for me. So if he needs to stop and rest, I document these rested, and I also document rest time off the stopwatch. I write down the rest time, and I actually encourage them every 15 seconds to resume walking when you feel able, because some patients think when they rest, that's the end of the test. So I would now say to him, when you feel ready, please resume walking, and then we continue on again. Thank you. You can take a seat now. I'll come and get that stuff off you in a second. Does that make sense until we go to the end? I don't know how much time I've got. About 5 minutes. So the only other thing I wanted to go through... Sorry? We've got 5 minutes? So the only other point I wanted to make is, let's say that this gentleman's 6-minute walk distance was 350 metres, and we know how tall he is. Let's say he's 1.67,
178.
178 centimetres.
Yeah.
So if you guys got phones here, can you do the maths to work this out? So let's say it was 350 metres. So if it's 350 metres, he's walked 3.5 kilometres in 1 hour. Multiply by 0.8 to bring it down to 80% of the average walking speed. Times it by 1,000 to get it out into metres. And then divide it by 3 to bring it down into 20 minutes if you wanted him to do a 20-minute corridor walk at 80% of the pace he maintained for that test. And then if you want to convert it into a work rate, 6-minute walk distance in here at 350, his height in here, 1.78. Do the maths, multiply it by 0.6 or 60%, and that will tell you where he starts on the bike.
So actually you started the training program 80%.
I started at 80%. But
no?
we manage it.
Is there a new patient that just
Yeah, absolutely. So for the first day, they might not get there,
No, yeah,
but that's the goal. That's the goal.
Ah,
so that's
the goal, okay. But not,
that's-
okay.
well, they're
The
walking
first
in.
week.
It is the goal in the first week, but they
yeah.
may not get there. And if this person had walked, if he'd needed to rest during his 6-minute walk test, straight away I'd be imposing rests in the training program. He'd no doubt need to rest, so you'd start interval-based training. And if his goal is less than, for ours, we work out if our goal is less than around about 1,200, they're likely going to need to rest quite a lot during the corridor walk. But the goal stays the same. That's what they're working towards. They're working towards 12 laps or 13 laps or whatever it is in your corridor. The other thing that is useful, I think if you're taking measures of SpO2, it will tell you if they're doing a corridor walk, how often they need to come in and be checked for their oximetry. Because if they're going to desaturate during the 6-minute walk test, they're going to desaturate during the corridor walk as well. So you may need, if they desaturate a lot, you may need to keep a closer eye on those patients. Sorry, I'm just turning this off. Sorry. Free you, huh? And you've got something on your back too. Thank you. Is that helpful? Does that make sense? Thank you for volunteering. It's very kind of you. No, it hasn't been prospectively validated. It was developed in 54 patients that were clinical rehab patients that came to a program. There is a paper that's attempted to validate it, and it's shown that it does well for the average patient, people at extremes of ages or people at extremes of heights. It doesn't do well, which you would expect with any regression equation. But this here was published by myself in Archives in 2008, and the validation paper is by a colleague called Anne Holland in Respiratory Medicine late last year or early this year. So you can look them up. You can look them up. But it has been validated, and like I said, it hadn't done badly except for the extremes, which you expect because regression equations aren't good at extremes. The only other comment I wanted to make, which I forgot earlier, is when we finish the 6-minute walk test, I usually carry 2 pens, and where the patient finishes the test, because patients don't do nice things like finish at the end of the corridor for you. They finish halfway down the corridor. I then put the pen on the floor and measure the rest of this distance with an odometer, with a wheel. So I always carry 2 pens for these tests, one to mark where the patient finished and one to write down the measurements at the end. So I can actually measure this distance. Any other questions?
Yes, please.
Yes, please.
What's your opinion about equation that can calculate the VO2 max from a 6-minute walk test?
Yeah, there are a few out there, I think, and I think you probably could. They'll have the same limitations as any regression equation. But I guess why would you be interested? Just to estimate what someone's VO2 is, to know what it might be?
You want to get baseline, you get intervention, and then you want to measure and to see in the norms.
Yeah, where they've sat.
Position.
Yeah, so I should think if you want to do that, you could do it. It's an indirect measure. It's not going to be as good as going out and getting the measure yourself, obviously, but you could certainly estimate. Most 6-minute walk tests, if they're done in this way, in kind of a maximal way, the correlation coefficient between VO2 and 6 minutes is quite strong. It's about 0.7, 0.78. So you can actually, but it's still an indirect way of measuring it. But you could estimate VO2 if you're interested from 6-minute walk distance. You'll probably do it better with an incremental shuttle walk test because that's what it was designed to do, replicate the incremental tests in the lab. So you probably do better with the incremental. Any other questions? Okay, well, thank you. I don't know if I've finished late, early, what's going on. So,
Thank you very much.
done?
Thank you very much.
You're welcome.